So I believe this is the 39th annual Marion Woodward Lecture. The first Marion Woodward Lecture was held in 1969, and again, over 300 people gathered to hear Helen Musalem, who was then the executive director of CNA, give a talk called Nursing Tomorrow. First, I'd like to thank our very generous donors, the Mr and Mrs P.A. Woodward Foundation. Mr. Woodward was one of the 4 sons of Mr. Charles Woodward, and they were the founders of the Woodward stores in BC and Alberta. And their foundation has as its mission benefiting the health of British Columbians, and they do a lot of work through the education of healthcare professionals. So this is a particularly fitting guest that we have tonight. The legacy book that's written by BC nurse historians tells us that Mrs. Marion Woodward never allowed her name to be used in conjunction with grants, but through the persuasive efforts of Beth McCann, who is a professor in the School of Nursing, she not only allowed her name to be used, but she also hosted a tea after the first one of these. So we'd really like to thank the Woodward family and the foundation. Second, I'd really like to extend a special welcome to our new Dean, Dr. Taysir Abdel-Nasser. Dr. Abdel-Nasser has just joined the UBC as the Dean of the Faculty of Applied Science, and we especially appreciate her being here tonight. Thanks. A couple of other special thank yous. We have with us Dr. Carl Wyman, who is Nobel laureate and education advocate, and he's the head, the leader of the Science Education Initiative here at UBC, and we're quite honored to have him. We're also very pleased that Val Cartmel, who's the president for the College of Registered Nurses of British Columbia, and our president-elect, Dr. Pam Ratner, are here with us. So there's many other people that I would like to recognize, and if I did that, we'd be right through trick-or-treating. And I'd just like to say, though, that we have with us many of our emeriti. Would that be emeritus? Emeriti? Yes. And many people who are leaders in clinical practice. We have practitioners, we have students, we have faculty from other schools of nursing, and I would just like to extend a warm welcome to you all. Our main focus, of course, is to hear from Dr. Patricia Benner tonight. And rather than beginning with any remarks from our director, Dr. Sally Thorne, we've asked Dr. Thorne to make some concluding remarks, and we've charged her with the task of reflecting on Dr. Benner's talk to really consider for us nursing tomorrow. So when we're done, we'll also have a reception in the atrium. So it's my great pleasure to introduce Dr. Benner. What nurse in North America doesn't have novice to expert? Either the book or at least that idea as part of his or her understanding of nursing and how nursing evolves. Dr. Patricia Benner is one of the most influential and internationally renowned contemporary nurses. Her 1984 book, Novice to Expert, Excellence and Power in Clinical Nursing Practice, has been really instrumental in defining nursing and in really highlighting clinical practice in nursing. And I think that it's helped us all really to examine how our practice, how we teach, how we learn, and how we do research. Dr. Benner particularly brings together practice and academic work in a very important way. Beyond that, I think that throughout her career, her work has been very important to nursing in terms of defining itself. Dr. Benner is currently Professor Emerita in the Department of Social and Behavioral Sciences at the University of California, San Francisco. And she's been a staff nurse in critical care, ICU, medical surgical areas, and home care. And I think that's Very important. She received her bachelor's degree from Pasadena College, her master's in medical surgical nursing from the University of California, San Francisco, and her PhD from the University of California, Berkeley, where she worked with Dr. Hubert Dreyfus and Richard Lazarus. She's the author of 9 books, including the Novice to Expert book, of course, and such other important books as The Primacy of Caring, which she co-authored with Judith Rubel, and Expertise in Nursing Practice, Caring, Clinical Judgment, and Ethics, which she co-authored with Christine Tanner and Catherine Chesla, which we know they've all contributed in very important ways to the curriculum revolution in nursing. Her books have received multiple awards, and in particular, Novice to Expert's been translated into 12 different languages. She's used her over 25 years of research in clinical development, nursing practice, skill acquisition, and healthcare ethics really to help nurses better understand their practice and to develop it further. At present, she's just completed the National Nursing Education Research Project in the United States, and that's been funded by the Carnegie Foundation for the advancement of teaching. And the work is both the basis of her talk tonight and her upcoming new book, Teaching and Learning in Nursing, A Complex Practice of Care. So, ladies and gentlemen, I give you Dr. Patricia Benner.
Thank you, Colleen. And indeed, it's a privilege and an honor to be in this legacy of 38 lectures before me. They're all very, very impressive. So I'm very honored and very proud. And I have been enjoying the beautiful leaves in your city. It's just breathtaking. So I will just begin. I want to give you the background of this nursing education study. It's an integrated comparative study of education for understanding the professions and education in the profession. And the 5 fields chosen were clergy, engineering, law, medicine, nursing, and teaching. And so you have engineering and nursing represented here tonight. And this is very important because the moral vision for this is to broaden our understanding of professionalism to a broader view of civic professionalism, an older, more Aristotelian view, and rescue it from the narrow technical professionalism. So it's no accident that they chose clergy, engineering, and nursing and teaching in this group, and there was no discussion, well, are they half a profession or semi-professional or whole professional, because it's not based on science alone or autonomy as the kingpin, but rather focused on how much weighty responsibility to the society and how much good and important work for making a good society are these professions. Well, automatically you would say, well, of course you want clergy and engineering and maybe law. No, I'm kidding. Nursing and teaching in there. Nursing and medicine were the only 2 studies that were conducted simultaneously and in dialogue. We made field visits, the site visits with medicine, and they made site visits in our schools of nursing. Each study involves intensive site visits in a set of professional schools chosen to represent really excellent schools. We weren't looking for poor performers. We were looking for really outstanding schools. And then we also sampled for geographical distribution in the U.S., East, Midwest, West. And we did a 3-day, very intensive site visit, occasionally 4 days. But prior to doing that, we did phone interviews, and we collected and studied course syllabi, and then This is one of our instruments that I would recommend for faculty development, and we borrowed it from and adapted it from the clergy study. But what we do is study the syllabus of the professor. In our case, we studied pivotal courses that all the other courses depended on. We studied the syllabus and then interviewed the teacher on the phone about the course and what she was trying to teach. And then we observed the class, took extensive notes, and then we interviewed the students and we interviewed the teacher again. And in many cases, what the teacher thought she was teaching and what the student was learning weren't very much in sync. I'm going to give you an example tonight in which they were in perfect sync. We also did, after we finished the 9 site visits, we did national surveys of nurse educators and nursing students in collaboration with the American National Student Nurses Association, the National League for Nursing, and the American Association of Colleges of Nursing. We asked questions that would extend, confirm, disconfirm aspects that we had found and thought we understood from the site visits. We asked questions on teaching, learning, and transitions into practice. And we had specifically questions for students about the experience of learning a practice, and you'll see some of those quotes tonight. Teaching for practice requires experiential teaching and learning, what we call situated cognition. It's a thinking in action, or the context is really important. This requires coaching and teaching when the student is ready to learn something, or they're in a really good situation to learn something. And teaching a practice requires that you reflect on particular cases and situations, because at the very heart of practical reasoning, which clinical reasoning is a form of practical reasoning, is a grasp of the nature of the situation. And it's within that boundary of understanding the nature of the situation, or changing your understanding of the situation if it's wrong, that you set limits on your approach and your inquiry and your interventions. We also, in teaching a practice, must teach the development of ethical comportment, something we've come to call formation. And it's not, this notion of ethics is not just in beliefs or decisions, or sometimes we have a problem of decisional ethics. But to give you a really good example, if you are the physician or the advanced practice nurse who writes the node code in the order, that is not more weighty morally or ethically than the one who removes the support equipment. So it focuses on comportment, and I think all the people with French heritage will be fine with that. But it's the notion that in our postures, in our way of being with people, that shows up in the way we comport ourselves, bodies forth our notions of good and our concerns in practical situations. So one of the things that we did in analyzing the 9 intensive site visits and the surveys is look for signature pedagogies. Now, in the law study, the signature pedagogy really is case law, teaching case law. Engineering is very interesting. It's about design. It's about problem solving. And I'm really going to commend that you take a look at the engineering study, which is on the brink of being brought out. In nursing, the signature pedagogy we discovered was ubiquitous everywhere, and it's coaching. It's drawing out what the student knows in bounded clinical situations. It's helping the student explore, make connections, realize what they know and how and why it's relevant to this situation. Now, this makes sense because in engineering, nursing, medicine law, it's situated cognition, and the situations are underdetermined. In other words, you can't really pre-specify the outcomes, and the situations can move in many different directions. So this situated coaching is essential. Questions to the students cue the students to relevant issues in the situation, particularly when they don't seem to grasp them. We had one instructor who would say, well, a prudent nurse might at this point. And the students could get the message. Often the teacher would think out loud so the student could see the teacher's access to the clinical situation. And what was really impressive to us is that we're really describing good coaching because the relationship of the teacher's coaching of the student was quite empowering, and it mirrors the way the teachers wanted the student to coach and empower and encourage patients. So there was a really deliberative kind of mirroring there that we thought was impressive. The goal is to prod experiential learning in the situation, and nursing faculty are really working on student self-confidence a lot. And I think this is because many of the things that student nurses do, they soon realize could kill the patient. And so they shouldn't act with bravado. Their self-confidence should not come from self-aggrandizement, but from real competence and real ability to act in the situation. The students are thrilled in their academic career to be in a situation where they are now really using the knowledge in the classroom in an actual situation. As one student put in the survey, being able to apply real-world skills soon after learning them in the classroom, being allowed to help real patients right now, gaining scientific and medical knowledge, helping society. I know I'm doing something important in the world. Well, this is a fabulous moral source that we have coming into nursing practice. We found very little cynicism, found a lot of engagement and excitement about becoming a nurse. In nursing, there's almost a universal, so I have to say that pedagogies of experiential learning are also real signature pedagogies of nursing, because in the U.S., almost all students universally engage in preclinical preparation. This is not so in medical practice. The student, I observed one of the medical students interview a woman with a colostomy trying to take the medical history and everything, and he really, at that point in his career, didn't know what that procedure was. This would not happen in nursing school, or very, very rarely would this happen, because the students prepare for their clinical by going through all the meds, the diagnosis, the patient's chart, and they try to be prepared to provide safe care. The other really universal feature in the U.S., I suppose it's about 88 or 90% of the time, is that there are these post-clinical conferences where students share what they learned. And if they've had a great day, they share that with enthusiasm. And they have formed a really wonderful learning community. The thing that was so remarkable to all of the Carnegie visitors who aren't nurses, and we thought was just ordinary, was that student nurses are quick to share with their fellow students when they've made an error or something didn't go well. Oh, I wouldn't want this to happen to you. And they give these cautionary tales. And I see you nodding your head. That's sort of universal about sharing the practice and extending experiential learning to other students. Now, I don't want to be too divisive here and draw too many doctor-nurse comparisons, but in medical school, there is such a remnant, a large remnant of competitive individualism. After all, it's been really hard to get into medical school, right? So we found that the medical students and residents would often fabricate what happened at the bedside to make themselves look better. And that's a kind of a problem. So we think they could develop their civic professionalism further if they understand that it's jointly owned and socially embedded. And every time we walk into a patient's room, we're standing on the shoulders of our fellow practitioners. And the student nurses really live that out in these post-clinical debriefings. They also focus in the debriefings on improving the practice. What can you do to improve what you did today, tomorrow? That also was really universal. I'm sorry. The teachers very actively pull students into discussion in the classroom, encouraging them to think about likely clinical symptoms for a particular condition. And often students present their own clinical experience as an example. And this was another thing that we found quite widespread in nursing teachers. They know their students. They know what they've done before they came to school, and I think that's very impressive. Lee Schulman says that one of the greatest educational handicaps for students is to be invisible or unknown, and we don't have a problem of that in nursing. The teacher, most often, and here I must say that really fine teachers draw on their own practice and teach from a stance of practice, and the students are really engaged by the discussion. Lee Schulman has taken this on his speaking because what he's doing now, he was the former president of Carnegie when all these studies were being conducted, and he's now involved in cross-professional comparison. And so this is one of the cross-professional comparisons he loves to take on the circuit, because nursing instructors typically teach the student for the action step, and we do have a problem in academia of having the action step overlooked a lot, with the abstraction and knowing the knowledge being quite sufficient. But we have an example here that illustrates what we're talking about. The instructor asks the student about possible complications to a prescribed narcotic. The student correctly answers respiratory depression, lowered blood pressure, decreased level of consciousness. And the teacher then asks, well, what interventions could be taken? Narcan to reverse the effects of the narcotic. Then the clinching question, where would you get the Narcan? What key would you need, and where is the Narcan located? That's the action step. And it doesn't help very much to just intellectually know it. You have to be able to find it and get it out of the Pyxis, right? All of the professional education studies were structured on the 3 apprenticeships, and we learned very quickly in all the studies that this is very useful for sort of categorizing in evaluation. But the image I want you to have is that these all 3 need to be integrated as much as possible. Once you separate them, it's very hard to get them back together. So the mental image I have of them is not a Venn diagram, right, that overlaps, but rather an ice core sample that goes down and puts them all together, mixes them all up. The first, of course, is intellectual training that provides academic and theoretical knowledge required for the particular practice discipline. And then that's where you really try to teach, regardless of the learning setting, the capacities to think in ways important to the profession. The second apprenticeship, now I must quickly explain, but apprenticeship is used here as a metaphor for the kind of complex practice that requires not just textbook reading, but real illustration and example. And clinical reasoning and clinical practice and skill know-how are the second apprenticeship. And I must say this is a very strong apprenticeship in nursing. The final one is formation and ethical comportment, apprenticeship to the ethical standards, social roles, and responsibilities of the profession, where the student begins to really integrate the notions of good and the visions and the skilled capacities to do good nursing practice. Now, notice the third apprenticeship is the most integrated, because if you don't do well in the first or the second, you can't do well in the third, because bungling is not really ethical. So we do not mean by these the usual. We do not mean sort of our former. In nursing, you always have to explain this. You don't have to explain this to the neurosurgeons. But these are all high-end apprenticeships, and they include simulation, skills lab, clinical classroom advising, include everything. So we wouldn't like you to compare like simulation with apprenticeship learning. That's not what we're talking about. And we're not talking about apprenticeship to a person or an institution. The other thing, it's very important when you're teaching anything to engage your learner at the cognitive skill level, the psychomotor skill level, and the affective skill level. So, but that's not what we're talking about with these apprenticeships. We're talking, I mean, this is more appropriate for particular teaching strategies and content. What we're talking about is that broader, more complex apprenticeship to an integrated, well-formed practice. And these apprenticeships include both tacit and explicit knowledge. When you think of the practice, the practitioner, they're always operating from a deep background understanding of a situation. They don't enter like an artificial intelligence machine, especially the old-fashioned ones, where they have to build everything up element by element. They enter with a deep background understanding. And if you're a human thinker, learner, actor, agent, you have, in order to perform, you have to have things in the background and things in the foreground. And what shifts from the foreground to the background has a lot to do with the situation you're in and your deep familiarity with the situation. Well, we have bad news. We found that the cognitive apprenticeship was really uneven and often inadequate in all the schools we studied. We found high variability, and we found a huge, what we began to call practice education gap, where the practice was ahead of the education that was going on. We found that students' evidence-based literature searching and questioning was weak. And we found a lot of, and this must be an American thing, it's a sort of Sesame Street fallout, a lot of teaching by entertainment, so a lot of use of games, and if you're just, sort of like entertained by Mary Poppins, maybe you won't notice you're learning difficult things. We found a lot, and we make this qualitative distinction. Distraction that may hold people's attention but distracts them away from practice, and engagement that helps them develop and imagine clinical practice and develop a very active clinical imagination. In the U.S., we found way too much teaching of testing strategies for the NCLEX RN exam. And this is a real problem for validity of that very exam, because the exam is based on the premise that you've graduated from an accredited nursing school, and that nursing school has tested your performance, your clinical performance, and is much broader than will ever be examined in the paper pencil exam. And when you shrink the curriculum, you give problems to the evaluation. We found, this is what's new in research, almost no interdisciplinary teaching. We found a lot of things on paper and high valuing of it, but no action. One of the students says, well, this is two different students. First student is saying, classes are not taught in a dynamic way. They seem to be taught in an old-fashioned science curriculum sort of way, when a different approach may be more suited. There's so much pressure to teach to the NCLEX. Everyone wants to pass, and it makes the school look good. And to teach the trade technical aspects of nursing, the human aspect of our work often gets lost or even dismissed. And I've had a frustrating time finding mentorship in that area. When I want to comment here that we found almost a silence. No, we found a silence in the classroom about coping, communication skills, caring practices. That was taught in the clinical, and sometimes in the simulation lab. It was like never mentioned in the classrooms, which tended to be much more abstract. Some classes were organized around presenting diagnostic categories. That's kind of an American disease, but it's also the informatics disease, right? I mean, because the computers are so good at categorizing and retrieval. So we had elaborate templates of signs and symptoms and nosologies of disease, and then, of course, the sort of outdated Maslow's hierarchy of needs. And the problem was that the student couldn't find the patient in all those taxonomies. Now, this is not a diatribe against the taxonomies. Students have to classify things, but they can learn that easily on the computer and in their textbooks. It is a waste of classroom time to do this kind of flat representation or presentational teaching. There was a real tension in the classroom between teaching everything a student needs for a transition to practice and teaching for a lifetime of practice. I mean, that's always going to be with us. And often what got short shift, we thought, were the focal practices of the relational aspects of nursing work. The impact on using what we now call a cataloging approach to teaching was to give descriptions of classifications of disease without strategies for approach and access to patient care or clinical imagination, except through the categories. So how do you take up care for the patient? And this has real consequences for access to practical reasoning. There's a wonderful maxim by Løgstrup, who is a well-known Scandinavian theorist and philosopher, and he says, subsuming things under categories is not the same thing as productive thinking. I've often thought that'd be a great mantra to put on my computer, because, you know, that's all the computer knows how to do. We found that students were overloaded and overwhelmed, and faculty were overloaded and overwhelmed, and we didn't know who caught what from whom, you know. But the students said there's so much to learn in such a short time. The most challenging thing is all the mountains of information that just has to be completely committed to long-term memory. Remembering normal lab values and drug dosages is hard for me. Well, of course, it's not a good safety practice. No matter how well you think you've memorized it, you should look it up and make sure your memory isn't faulty. The integration of classroom and clinical this is a very tactful way to say it, uneven. Actually, it was radically separate. As this student says, some students are lucky enough to obtain a clinical instructor that also teaches the course. Then the course objectives and content are better facilitated with direct clinical setting examples. For example, there might be an instructor teaching remember We talked about this subject in class. Here's a prime example of that. Lecture in the clinical setting. This exempling solidifies classroom taught information student. We need to redesign the curriculum for classroom teaching to upgrade the cognitive apprenticeship. We need to think about creating clinical imagination with every classroom. We need to teach for authentic engagement and problem solving in the practice, because it's gripping enough if you do that well. And catalogs and taxonomies should not be the main scaffolding for organizing classroom teaching. And I'm going to give you a nice example of a teacher who does that. Now, the second apprenticeship is much better off. And when we went into the study, we thought, oh, well, that's where we're worried about. And I think that's a sort of universal thing with nurse educators. We always think we've got to do better at clinical instruction. We've got to do better at classroom instruction. So this is where you learn skilled know-how and the habits of mind required for performance and for competent practice. Central for this is teaching for a sense of salience. In a clinical situation, some things, once you have been really inducted into interpreting those ambiguous, underdetermined clinical situations, eventually a wonderful, magical thing happens, and some things just stand out as more important and other things less important. That's not true for the novice, and it's really frightening. Having a sense of salience about multiple clinical situations makes it possible for you to grasp the nature of the situation in clinical practice and identify key nursing concerns. This need for understanding the situation limits the tried and true pedagogical strategy of breaking things down into elements and then teaching them out of context of practice. Don't do that more than about the first quarter, when you're really having to work with students who have no access imaginatively to practice. Because you have to teach holistically, what's the nature of this situation and how do you respond to the situation? This will really shock you. We have limited good clinical placements for student nurses. In the U.S., we're relying a great deal on staff nurses for teaching without mentoring those staff nurses in teaching. Now, the really sterling example I mentioned earlier today is University of Washington. If you're doing clinical teaching and you're paid by the hospital and maybe given only a small amount from the university, regardless of all of that arrangement, you're brought in and taught how to teach, and you're a part of the team teaching meetings, and you go over the syllabus, and you have a discussion with the classroom instructors about how particular students are learning. And so this makes the clinical teaching so much more interesting. And when someone has finished doing this, that's a real gift to the practice institution, because they have now a better clinical teacher. And in clinical practice, everybody needs to be a good clinical teacher. We found that there was a lot of confusion and high variability over what is critical thinking. Every kind of thinking and virtue you can imagine in nursing is called critical thinking. And that's actually not so bad, because it would be worse if we really were only teaching critical thinking. That would be a disaster for a practice profession to only teach deconstruction and how to abandon past hidebound views that no longer work. Because in a situation, the practitioner has to have a stance. And in a resuscitation, it is no time to reconsider Harvey's direction of the blood flow. And so people really they would really conflate. I mean, critical thinking was any kind of good performance or critical or thinking at all. So clinical reasoning is reasoning across time about the particular through changes in the patient and changes in the practitioner's understanding of the patient and the family. We found that situated clinical learning was especially strong when clinical faculty rather than staff nurses coach students in the clinical setting. And as I mentioned earlier with coaching, that situated teaching and learning and coaching in the practice setting was really quite strong. Now, I went to the National Student Nurses Association with my colleague Molly Sutphin, and we were presenting the results of their survey and this study. And I said, well, before I present this, just let me ask you, how many of you think classroom instruction is stronger than clinical instruction, is better, is done better? No one in the 3,000 audience raised their hand that we could see. I asked, how many of you think clinical instruction is stronger and better, higher quality? The whole audience raised their hand. So I thought that was validating. It was kind of... I do want you to know that they played this sort of rock and roll song with the big speaker. I mean, going to a student nurses convention is really wild. You've got lots of rock and roll and lights and all of this. And so we finished speaking, and on comes the song, "She Works Hard for Her Money." It was a real moment. Pedagogies of being with and responding to suffering are excellent in clinical teaching arenas, but they're almost absent, as I mentioned earlier, in classroom teaching. Students describe in their narratives about their learning, about really transformative learning experience in learning from patients. But faculty don't often ask about this. It only gets told occasionally in the post-clinical conferences. What a great student-generated text it would be if all the students wrote up their narratives of what they learned from their patients and then made that a text that all the students read. The students highly, highly value the added time that they have when their assignments are only 1 or 2 patients. They tell us adamantly they couldn't learn to be a nurse if they didn't have this reduced patient load. And they worry about the day when they'll have so many patients to take care of. But they insist that they need the time because they're so slow. And they need to learn how to develop a relationship. This makes sense to me. As one student says, I have had the honor of being present with and learning from clients in intimate, vulnerable, scary situations. I get to regularly advocate for the underserved, especially in the hospital setting. I have access to environments I would have otherwise never been exposed to and have learned and grown and broadened my world perspective. You couldn't ask for a more engaged, passionate student. The third apprenticeship to the ethical standards and ethical comportment, skilled know-how. Well, what the clergy taught all the rest of the studies, and it did come first, was that because they had been kicked out of the profession hoods during the technical professionalism where science was really important and autonomy was the kingpin, they didn't buy into a thin veneer of socialization. They said, no, the minister, the clergy, the rabbi has to be formed. And it's important that their experiential learning create new capacities to see and act. And I want you to use that as a thought experiment. How did your way of being in the world and a way of perceiving, ways of perceiving change as a result of being in nursing school? We found that ethical comportment and formation were a pervasive concern in the classroom and clinical practice. However, when we asked specific questions about teaching ethics, both faculty and students thought we were talking about bioethics, and they never mentioned everyday ethical comportment. They never mentioned relational ethics. So students and faculty alike tend to imagine ethics as abstract principles and often do not recognize when their own concerns in practice are ethical concerns. This tells me we need to broaden those ethics classes in nursing. Dilemma breakdown ethics does not teach you very much about everyday ethical comportment and good practice. Here were the examples of ethical concerns that we found in the student nurses' senior narratives. Meeting the patient as a person. And this was such a big deal. This patient was a person, and I came to see the patient in a new way as a person. And I thought, if we hadn't been so busy categorizing all these patients, maybe they wouldn't have to discover that. A second concern was preserving dignity and personhood of patients. And then a major clincher that we talked about earlier today is how does a student nurse respond to substandard practice? They often feel powerless. They are given many messages not to create too much havoc for the other nurses. And so this was a frequent mention of ethical concern and dilemma for the students. Advocating for patients was pervasive in the narratives, but it's so broad and so interesting, this advocacy tradition in nursing. It means so many things, like standing alongside the patient, being a surrogate when needed in defending and protecting the patient. Making sure all the medical treatments are not going at cross purposes. Making sure there's no contraindications or bad interactions among treatments and medications. So this is a very interesting, broad area of everyday ethics in nursing practice. And we had so many great examples of engaging fully in learning to do good nursing practice. It was pervasive that how am I going to improve tomorrow? How can I do my care that I did today better tomorrow? And there was a usual response that it was really better today than it was yesterday. And that was what the goal was all about. A student says about her experience, the amount of information to be learned is overwhelming, but none of the content is actually difficult. Sometimes it feels as though the tests are deliberately confusing because the material we learn is so simple that if the questions were presented in a straightforward manner, everyone would get A's. First problem, standardized tests that don't test my actual knowledge or anything I value. Continued. Second problem, an emphasis on skills when these are the easier part of nursing. Bedside manner, social interaction, calming difficult patients, dealing with intense emotion, communication with patients with whom you do not share a common language are all much harder than learning to start an IV. Yet the emphasis on skills over theory and thought pretends otherwise. This is a wake-up call, I think. I mean, this was said by a student. And one of my colleagues from Australia, whose name I can't think of right now, surreptitiously videotaped a skills lab and found that 3 hours were devoted to teaching blood pressure. That's a waste of students' time. We teach it to patients in 10 to 20. And the complexity of blood pressure is in the interpretation. So what is needed? Add-on solutions will not work. The 3 apprenticeships must be integrated as often as possible. And we need a real upgrading of knowledge and skills in all of the apprenticeships. We need to upgrade the science in particular, and the social sciences also. So we came up with these primary major paradigm shifts from a primary emphasis on critical thinking to multiple ways of thinking with an emphasis on clinical reasoning. This may not be such a shift in practice, but it definitely will be a shift in language. We're probably already doing that a bit more than we imagine. From curricular threads and lists of competencies to integration of the 3 broad high-end professional apprenticeships and the integration of classroom and clinical teaching. Remembering that knowledge use is not the same as knowledge acquisition. And knowledge acquisition without the ability to use and act is not very impressive. From abstract theoretical classroom teaching and the very virtuous notion of application of that theory to clinical practice, to teaching for a sense of salience and situated knowledge use, teaching and interpretive dialogical use of theory in practice. That's a very different metaphor and image than taking a template, a theoretical template, and stamping it on an inert practice. Rather, you're always open to clinical inquiry, you're using dialogue, you're coming from educated guesses and from lots of thinking from the theory, but you don't imagine that you do not have to situate or select the appropriate theory and engage in adjusting and adapting it to the particular situation. So from socialization and rational technical professionalism and role-taking to formation that really includes a deeper learning and developing all 3 apprenticeships in an embodied, skilled know-how way. And one of the things that I think would be fabulous if university schools would introduce just one seminar in freshman year, one seminar in sophomore year on nursing that would help the students connect all of that first year, the 2 years of prerequisites, but also begin the formation process earlier. Now, I recognize late adopters would have to be taught the summer before entering nursing school. Summer before entering the nursing part of the curriculum, but we could do that. This is for the U.S. only, but we have got to do something about the disjointed AD entry in and move that to a seamless integration of BSN degree through cooperative and collaborative education programs. I don't know if you know, but our quote-unquote 2-year community college take anywhere minimum of 3 years, usually 5 years, and sometimes 7 years. And most of that extensive time waste has to do with waiting times to get into classes. The other major problem is that there's often 50, 60, 70% dropout rate because so many colleges use complete open enrollment. If only they would adopt to people with the highest scores in their prerequisites are in the top list for open enrollment. Small shift would save a lot of money and produce a lot more nurses. We're recommending the wonderful consortium program developed in Oregon. I don't need to talk about this a lot, but anyway, we've got to fix that in the U.S. So we've got to, I think this is a repeat here, we need to enhance collaboration and responsibility for excellence in education of nurses in all sectors: practice, education, accreditation, policy making. And we need more integration and exchange between practice and education sectors. It's time to realize that we move back and forth between these two sectors, that collectively both sectors own nursing and hold nursing in their hands. So we need to act as if we're in the same family, and we need to stop pointing fingers of blame, because you might switch your position just in a year now. I'm going to just close with giving you an example of what we think integrative teaching looks like. We were taught by Lisa Day, Diane Pestalozzi, and Sarah Shannon. Each of these teachers we've used as exemplars or paradigm cases in our book. Each teaches for a sense of salience, each integrates the 3 apprenticeships, and each teach from a stance of practice. Lisa Day scaffolds her or organizes her whole class about, based on these 5 questions. What are your concerns about the patient? What is the cause of the concern? What information do you need? What are you going to do about it? What is Mrs. G experiencing? And then she presents Mrs. G as an unfolding clinical case where the lab values come in at different points in the trajectory. She's chosen this patient who had sepsis and was HIV positive, now moving into AIDS. And Mrs. G unfortunately has to be intubated, and so she takes the students all through the 100% oxygen rebreathing trial, and then more blood gases, and then how to make a case to get intubation before it's a crisis. We recommend these 3 reflective questions for evaluating your teaching. And if you're a teacher and you haven't been using Pat Cross's wonderful 1-minute feedback sheet, I really recommend it. How many of you have ever used that in your classroom? It's just so powerful. You say to the students, what was most important about today's class? What did you not understand? What did you disagree with or have conflict or concern about? And short answers, and then they're out the door. The teacher learns a lot about what they've been teaching. So can the student imaginatively access and rehearse for practice situations based on the way you teach your classes? What is the student's stance in relation to the patient, to the teacher, and to the other students? So Lisa Day uses unfolding cases to rehearse reactions, plans, and goals in practice. She also draws on her extensive experience in an emotionally nuanced way from which students find a moral compass in their response to actual clinical situations. They actually gain a moral vision for ethical comportment. Each of these teachers will tell a trying moment or a time when they made a medication error. And in the way they tell the story, you get their sense of the importance of integrity, the sense of urgency for honesty, and trying to limit the damage to the patient. So I've kind of gone over that. Lisa is keen to have the students grasp the nature of the situation, and she's keen to have the students identify nursing concerns. And please don't try to read this, and I can make the slides available for you. When we ask her how did she teach for character development and ethics, she said, well, we can talk about the specific technical skills that we need and what we need to look out for and watch out for, but I am trying to show them what's at stake and then ask them, what do you think we should be paying attention to? Paying attention is a moral art, you know. That gets a character development. These are the questions you should be asking, and these are the concerns you should have, and these are the responses that those concerns should generate. This is a way of trying to develop a habit of thinking that is patient-focused and focused on what is at stake for the patient. She's so clear about this, and the students are equally clear that this is what they learn. So I'm going to just tell this story quickly, and I'm not going to read it. But she teaches in a master's entry program at UCSF, and she had a very bright student who was terrified of ever putting down an NG tube. So she cleverly avoided any assignments that were remotely related to GI obstruction. And she said, oh no, this is the quarter, I've got to face up to this. She just, for some reason, was phobic about it. And so she signed up for a patient who was likely to get an NG tube the next day. She did all the prep for it, and she didn't sleep very well, she says. She heard in report that the patient really needed an NG tube because she had this bowel obstruction, but the patient was refusing the NG tube. And she thought, oh, thank God. But when she went in to see the patient's abdomen was so distended and taut, and she was throwing up the bile, and it was so awful. And she realized, she figured out the best thing she could do for that patient was to talk her into the NG tube. So she and the clinical nurse, who had seen the good results of NG tubes, where the student had never seen it, talked her into it. And then this is actually written up by Lisa and the student, where the student says she was embarrassed to look back at how self-focused she was, how narcissistic she was in wearing over the NG tube, because when she actually put the NG tube into this woman who was really suffering, and it relieved the woman's suffering, it was no longer about her. It was about the patient. It was no longer about learning a skill, but being compassionate and taking care of the situation. No longer a notch on her skill belt. As Lisa Day says, it was the most appropriate response in this situation. It was the first thing that she could do, the best thing she could do for her patient. She was led by that concern rather than her own self-focus. And the student says very much the same. That's the really wonderful part about interviewing students and teachers with these excellent teachers. They're very much in sync. When we ask Lisa about what she tells the students about this class, she says, I tell them that this is a really heavy, difficult course, not because of the academics, nor all the studying and memorizing that they are going to do, but because of what they are confronted with in the clinical setting, and because of what is at stake in terms of taking care of patients and doing the right thing for patients. That's integrative teaching, right? The very questions she scaffolds the class with is integrative. When you sit in her class, you too are placed in this collaborative nursing role with Lisa. It's as if she's a clinical nurse specialist and you're all gathered around and you're thinking your best about this case. The case is presented in terms of patient nurse concerns, what the patient is experiencing, what actions should be taken by the nurse, and the student is asked to respond to the patient's situation. She takes seriously the students' contributions to the class, and she knows her students very well, and she calls on them related to their expertise, since they're a baccalaureate second degree program. Her cases always evolve over time, so she can teach trends, trajectories, reasoning across time. I'm going to end with this wonderful statement from a student, because I think it points to a huge moral source in nursing and nursing education. This student says, many of my professors, this was from the survey, are wonderful and inspiring, and I know they earn next to nothing compared to what they could earn in the hospital. So I have a lot of respect for them. Nursing school is the most challenging thing I've done in my life. But there are those moments with my patients when I'm reminded of why I decided to become a nurse, and I feel it's worth it. I can't wait to become a nurse because I can't think of a greater career with more opportunities. I look forward to a career that I will love most of the time. And the opportunity to provide much needed service to society. And I feel that nursing is not just a job or even a career, but part of who I am. I already feel that transformation. I'm starting to look at the world through nurses' eyes. That's formation, that's integration, and that's our goal. Thank you.
We have a few moments. We could take a few questions or responses, but when you do, would you please stand on the pad at the microphone? So,
oh, that's in the aisle there. If you can't see it.
You've stunned them into silence.
Ah. Yes, okay, come down. This is good Canadian style. She's avoiding the middle aisle. No tall poppy here.
Sorry, I haven't seen the middle aisle. But my name is Gertje, and I'm part of the faculty here at the school. And I was struck at one moment during your talk when you talked about information overload. And that raised the question for me, not only because I'm a nurse, but also because I'm a parent, and I'm facing this new generation that goes through a completely different experience than I have ever gone through myself, and that is being day-to-day immersed in exposure to digital toys in many ways. And so I know amongst my colleagues also we have these discussions as to whether we should feed into the information overload and go more technological, or whether, or maybe I should frame it differently. Is that even a valuable dichotomy?
Well, you know, there's I saw an incredible video that was presented in a conference the other day, Did You Know? And it talks about the exponential rise in information and all of the new capacities of the computer, and also just the global experience where if you count all the brains and the IQs, we don't have the most of any of that. And so, I mean, you could just sort of become discouraged listening to all about the information explosion, how fast knowledge is growing. But guess what? Computers are really good at storing and retrieving information. They are not very good at deciding what the nature of the situation is. They don't get salience at all. They have what is called a frame problem, in that they can't determine what the nature of the situation is, and they have a sequencing problem. They don't understand why the meaning of what has gone on before influences the subsequent meaning. So instead of having our students mimic the computers, we need to augment them and make them much more intelligent as human beings and human experts rather than computer experts. And we need to have them augment their savvy and their knowledge with the use of the computer and intelligent use of the computer, but we must be so careful not to mimic the wizardry of the computer. And if you haven't read the Dreyfus book, What Computers Still Can't Do, I really encourage you reading the updated version, but if nothing else, just go and read the contrasts, the alternative assumptions about human experts and human thinking, and let's focus on that and the intelligent use of computers, because we'll become sub-intelligent if we just try to make ourselves mimic huge volumes of information in categorization and retrieval. Yeah.
Batorf, speaking from UBC Okanagan, our second campus. Thank you very much for your talk. It was really inspiring. You mentioned that there wasn't much in terms of interdisciplinary learning that you observe. There's also a lot of talk here about interprofessional learning. And so I'm wondering if you have any suggestions about what place interprofessional learning might have in nursing and perhaps beyond, and if you have any ideas about how we might accomplish that.
Well, this was a major agenda for Carnegie, and because nurses and physicians work so closely together, and we know that when their communication improves, patient outcomes improve. We have research on that. We haven't found a way to bring physicians and nurses together in their education. Physicians are so ignorant about what nurses do. I mean, it is a problem of being the dominant profession and not needing to know what the other group knows. I was amazed when I saw how absolutely enchanted with the intellectual task of diagnosis in medical school. It's a fetish in medical school. And they look very hard to find the undiagnosed patient. Do you know how hard it is to find an undiagnosed patient in our current medical era? So when I would bring up, well, what about the charge of carefully titrating and balancing multiple chronic illness treatments? Let nurses do that, they would say. And they really don't get it. I mean, there is a way in which their enchantment no longer matches their practice. I mean, although I think diagnostic acumen is very important, I don't denigrate it, it's just that it's not the only enchanting, exciting thing to do in healthcare. So physicians need this just as much as nurses need to understand better how the physician thinks. Our nursing students aren't being taught adequately how to make a case to physicians, and we need to do that in simulation labs and practice sessions and teach them to make a strong argument. I recommend that ISPAR program that talks about really stating what you're thinking and how your interpretation is going, so that it's not a doctor-nurse game, but it's making an honest, direct, open case. We haven't figured out how to do it. I wish you guys would do it in Canada and then ship it over the border. It is a little problem that it's going to be a little bit easier to integrate the second-degree nurses with medical students because they have the same educational background. But, you know, we just have to figure it out. And I don't know how to do it yet.
I'm operations leader for cardiology at Providence Healthcare, and it's indeed an honor to listen to you this evening. I've read many of your books, and I feel quite influenced by some of your teachings over the years. My role is hiring brand new grads, and I have to tell you, I've been doing it for about 4 years now, and I am excited by the people that I have the opportunity to hire into our area. And we have a very high acute area, cardiology. They're very sick, and we have high expectations of our students, and it's exciting, and it's I don't know, it's very invigorating to me because I've been a nurse for a very, very long time. And I have to tell you, what you're proposing, it makes sense intuitively. And it could be because I've been a nurse for a long time, or maybe it's because I was educated by hippies 30 years ago, you know, so it just sort of all comes together now. And maybe it's because over the years, experience has told me that is the way we should be doing it, right? That it is not just skills, it's not just tasks. It's that in-between stuff that really makes a difference for our patients.
Yeah.
And
it takes courage, doesn't it, to call a break in sterile technique?
Yeah.
Yeah. There is so much intellectual content and skilled know-how and knowledge used in the OR. I'm ashamed of the dark period when we thought, well, that's just technical. I apologize for that because it's ignorance that would make us say such a thing. But it is quite wonderful, and new graduates do far better in localized, focused specialty practices than they do when they enter a broad med-surg situation where they see such a broad range of patients that it takes them a long time to get in-depth experience.
That's right.
So
and I think one of the challenges is that often people they think that they've got expertise quickly, so they don't have the patient to develop that in-depth experience.
Right.
The other thing I would just put out there, and I think this is a challenge for people in roles like mine and those of us who support practice in the hospitals themselves, is that we need to have patience with students who are learning a different way of being. And we need to encourage our colleagues not to dump on students who don't have the specific skill set.
No.
Because that's what tends to be the critique, and that's not fair.
It isn't fair, and those that are doing that have forgotten what they were like when they were new.
That's right.
I had a student once, a master's student, who did this incredible video. I wish I would have, I wish we'd had DVDs at the time, But she did this where she had an OR nurse, an expert, gown and glove, and it looked like ballet, right? And then she's carefully following, and she's doing everything along the way. And it's slow and it's klutzy, and she's, just being aware of every aspect of clean, sterile, and dirty. And she gets through it. She looks exhausted, and she says, "That wasn't bad for a first try, was it?" I've always loved that because it shows how hard, and it's so weird in the neonatal intensive care units. They'll do something like draw a procedure for small baby bundling. Now, I have a lot to tell you. These hands would not know how to hold those little 1,000-gram babies and even turn them over without breaking their necks. I mean, there's skill in that, and it's skill know-how in the hands, right? It's frightening. At least I would do it slowly enough because I'm aware, But we have this kind of representational sight is everything culture, and we have to extend that to touch and feel and action, and we mustn't make it a lower form of knowledge because it isn't.
That's right.
Yeah.
Thank you very much for your work.
Over here. Go closer to the mic.
Is it better?
That's better. Okay.
I'll teach at Langara. And thank you for this evening and also for your many writings which I've come across along the years. And what I wanted to bring to you is it might be different between the two countries, the US and Canada. I find a lot of my students feel that they're just a nurse or they're just going to be a nurse. And what I say is that I'm a whole nurse, so I don't know about you. I'm not just a nurse. So do you have any other insight into helping our students feeling very prouder maybe about their accomplishment in nursing?
Oh, yes, because, Pat Cross, who does the 1-minute evaluation, is a fabulous educator, and she read our manuscript and really liked it. It was a wonderful moment for us. And she said, this is one of the hardest professions I've thought about, much harder than teaching. I think it's a really hard, complex practice with so many layers and levels. Not very many people can pull this off. And that's true. It's like the best kept secret, right, for how difficult it is. It's a little like the secrets about parenting. When you actually do it, it's pretty hard. Thank you.
there's no easy time to cut off the questions because Dr. Benner is so interesting, and I know that you will all stay afterwards for the reception and you can ask your continuing questions one at a time. I'm Sally Thorne, Director of the School of Nursing, and Dr. Benner, as we all know, has brought her outstanding career as an inspirational thinker and philosopher of nursing here to us tonight to inspire us and excite us once again. Her career has been full of this continuous blend of the practical and the applied, and we've heard that delightfully represented today. And those two blended are always informed by the highest level of complex thinking. She's created visions toward which everybody in this room has constantly strived. I have the opportunity of saying a few words in response and commenting a little bit about what we here at the School of Nursing are doing about this educational challenge and in response to the desire to do the very best we can educationally. As you know, we're a very early school, next year celebrating our 90th anniversary. We have a sustained record of leadership and continuing developments in scholarship. And the school has been continuously fueled by a sense of itself as being all about that fundamental common core of nursing practice. Despite our diversity as a faculty and as a group, that is the fundamental core to which we direct our attention. All of our faculty are nurses, and they're all passionately committed to nursing. In fact, they don't get to be hired unless they demonstrate that according to some criteria that we set. That passionate commitment to nursing is fundamental to what we all do. And being part of this particular faculty just inspires me on an everyday basis with the depth, integrity, and thoughtfulness of this passion. Dr. Benner, you've come to us at an incredibly opportune time. Earlier this week, the UBC School of Nursing committed itself to a new curriculum based on an integrative ideal. And our faculty have organized themselves into active teams to bring this curriculum into being by September 2009. It's taken several years of deep analysis, synthesis, and vision within the faculty to bring this particular plan to light, and to work with our government and our regulators and our employers to ensure that this vision is the right one. We have an accelerated upper division second degree program, and you'll be pleased to know that we are working very hard on continuing to perfect the art of the highly selective admission that we do. We select not only for academic aptitude, but also for clinical aptitude, and are quite committed to the value of the investment of time and effort into that. It's complex and it's difficult, and we'll continue to evolve over time to make that better and better. But we are committed to trying to fill those seats with those who are going to succeed. We bring students into our program who have diverse backgrounds in any other discipline you could ever imagine. And 21 months later, they leave us as an excellent novice nurse. And with our new curriculum, we know we're going to take all that we already offer, all the strengths we already bring, and enhance it with this commitment to integration, which is very much what you're speaking about tonight. So your intellect and commitment and your sensible advice is going to inspire the work that we've already planned to bring into fruition. We know that it's actually going to require, we know intellectually at least, that it's going to require some stretching and challenging as we refine our teaching approaches. And so your comments tonight have been delightfully pointed with regard to helping us reflect on that which we can take pride in, that we do pretty well actually, and that we absolutely want to preserve, and the places we still want to improve over time. We're really privileged as well to be part of a university that's set a very unusual sight for itself. Within world-class research-intensive universities, our university's taken a commitment to say undergraduate education actually can aspire to excellence, and we can develop the pedagogical tools and strategies to bring us there. So we have some tremendous leadership and inspiration within this university to help bring that to fruition. So we're well positioned as a School of Nursing for that. But we know we're going to have to work very differently across our teaching teams and our structures. And you've given us, I hear my colleagues busily taking notes tonight on all the detail. We've got to change many of the ways of teaching to which we've become accustomed and test ourselves as we engage with the substance and the process of facilitating new ways of learning. I think that despite the fact that our curriculum being fairly well developed now, I very much imagine that in the next incarnation we'll see objectives and learning experiences related to civic professionalism and clinical imagination, situated cognition, ethical comportment. We'll manifest in the curriculum implementation that coaching that you spoke about and remembering the action steps. I think that model of the 3 apprenticeships is a delightful model, not only for its substance, but also because it's reclaimed a language that's been something like a 4-letter word. Words like service and apprenticeship seem like an old way, and yet I think we can reclaim them and say that is the essence of what we do, and we can learn to do it thoughtfully and intellectually. You've also challenged us to really pay attention to the classroom and the many ways in which we need to modify classroom. Clinical education becomes a focus because there's so many challenges in the current context, but the classroom has to be something other than distracted entertainment. We have to be teaching for a sense of salience, and you gave us some delightful examples about how that acts. And when I look around, I'm very proud of so many of my colleagues, award-winning educators, and I know I see that same kind of educating for salience and clinical relevance and engaging students in thinking and owning that learning. You've also talked to us about paying attention as a moral art, and that brings that nursing reasoning down to that moment and challenges us with engaging in such a way that we remember it's who we are being as educators that's providing that learning experience. And as we do all this work, we're going to be increasingly working closely with our service partners, many of whom are here tonight, because we have a solidly established commitment to finding new ways of engaging with them. We're very excited to have had the opportunity to work very closely with colleagues in the service sector, government, the Nurses Bargaining Association, and other universities to try and help rebuild layers of clinical educators within the service sector, and then to work toward creating that more seamless integration between the university and the service sector. This isn't the kind of project that you accomplish in a year or 2 years, but it certainly is our 5 or 10-year vision, and we will get there. We're going to take that commitment even further with our vision of practice academic collaboratives, in which we bring the research into the clinical context, and we align that with clinical education and the retention and support activities, because we all really are aiming for the same thing, and the kind of climate that is an excellent learning environment is also an excellent working environment. So the enthusiasm for this kind of change, well, we've had lots of change in the School of Nursing, and we've leapt into it, and we've taken the lead before. I think we sometimes need to fuel our batteries. And so the opportunity to have you here tonight has been just absolutely incredible. And I know that you've been fueling our batteries and giving us courage to know that even though some of us might be a little daunted and saying, what's this actually going to mean now that we've approved it, you've given us courage to say, now we actually can figure out how to do this. So when we were lucky enough to secure you to come for this historic lecture, and you are one of a list of incredible people that we've been honored to have here at the school, we had no idea that your coming would coincide with what I think will be a transformational shift in the school. But we'll remember this linkage, and you will be forever stamped on this linkage. We'll take your words of caution and your words of advice and inspiration as we go forward. So we thank you so much for the remarkable career that you've devoted to the business of making new nurses and to supporting the development of nursing practice. You're truly a giant among a marvelous collection of wonderful thinkers in our discipline, and we so appreciate your timely words of wisdom to us tonight. We have an extremely small token of appreciation. We know the core of nursing is the sort of mundane and everyday, things like bodily comfort and dignity. We know you also live in a climate which is generously endowed with liquid from the heavens. And we know you like practical problem solving. We're fairly sure an engineer would have invented the simple umbrella. But we'd like to honor you. Perfect. The School of Nursing umbrella. Thank you so much, and please join us for the reception.
The reception is immediate, and it's just outside to the left in the atrium.